Welcome to The Explainer. Today, we're jumping right into an epic microscopic battle that is literally happening right now inside millions of people. We are talking about rheumatoid arthritis. Just imagine your body's ultimate defense system, this incredibly fine-tuned machine, suddenly turning its highly evolved weapons against your very own joints. No, it's not science fiction. It is the harsh, dramatic reality of autoimmune dysregulation. We're going to break down exactly how this happens, how we can spot it early, and the medical arsenal we use to fight back and reclaim the body.
Section 1. The Internal Joint War, when the immune system goes rogue. Okay, let's dive into this. So, let's trace this invasion. It's essentially a massive communication breakdown that happens in rapid, cascading steps. Step 1. Immunoglobulins mistakenly activate the complement system. Boom. This instantly triggers Step 2, where pro-inflammatory cytokines, think of things like TNF-alpha, which are basically the body's chemical alarm bells, just flood the area, kicking off unrelenting inflammation. By Step 3, cleanup cells known as macrophages get stimulated and start releasing destructive toxins. And finally, Step 4. All this cellular chaos causes the joint tissue to wildly proliferate into a mass called a pannus, which literally invades and erodes the surrounding cartilage and bone. It's just a rapid, self-feeding loop of total destruction.
And fueling all this chaos are these signaling molecules called Janus kinases, or JAK for short. Think of these JAK molecules as enemy radio towers. This specific kinase regulates cell maturation and cytokine production, so it's constantly broadcasting the signal for more and more leukocyte troops to enter the joint. It's effectively maintaining and amplifying that destructive inflammation.
Now, you might be wondering, what does this microscopic warfare actually feel like for the patient? Well, the battlefield aftermath is devastating. Vasoactive substances like histamine and kinins massively increase blood flow and vascular permeability. What this means is profound edema, warmth, erythema, and severe pain. As granulocytes pour into the joints, the end result can be a complete loss of joint space and motion. And eventually, this leads to bony fusion, known as ankylosis, and chronic irreversible deformity.
Moving on to Section 2, Identifying the Enemy, Clinical Presentation and Diagnosis. So, how do we spot it? Our early warning signs often start pretty subtly. Patients might just experience nonspecific fatigue, weakness, or maybe a low-grade fever over weeks or even months. Then the joint pain sets in. It's typically symmetric, meaning it happens on both sides, usually affecting the small joints of the hands, wrists, and feet. The tissue feels soft, spongy, warm, and swollen. But the absolute most crucial clue here, joint stiffness that is significantly worse in the morning and exceeds 30 minutes. Let me repeat that. Morning stiffness lasting longer than 30 minutes, that duration is a massive red flag that we are dealing with systemic inflammation.
When rheumatologists are evaluating a patient with unexplained joint swelling or synovitis, they rely on diagnostic criteria from international governing bodies like the ACR and EULAR. And the magic number here is 6. If a patient gets a combined score of 6 or more out of 10 on these criteria, that indicates definite rheumatoid arthritis. That score of 6 is our definitive confirmation that the war has absolutely begun. A big part of that diagnostic score relies on lab intelligence. Looking at the prevalence of seropositive results in RA, we see about 65% of patients are positive for rheumatoid factor, and up to 68% test positive for another antibody called ACPA. So why does this matter? Well, because seropositive patients tend to face a much more aggressive, destructive course of the disease. These lab values aren't just a simple diagnostic checklist, they're literally threat-level indicators.
All of this brings us to the ultimate question. How do we stop the progression and actually reclaim the joints? Once we've gathered our intel and identified the enemy, how do we deploy our medical arsenal effectively to turn the tide?
The answer lies in DMARDs, disease-modifying anti-rheumatic drugs. These are medications started as soon as possible after disease onset that actually slow down RA disease progression and delay disability. So the crucial point is that early deployment of DMARDs results in far more favorable outcomes. We aren't just sitting around waiting to manage the pain, we are striking back immediately.
It's absolutely vital to distinguish between a quick fix and a war-winning strategy here. Things like NSAIDs and corticosteroids provide rapid symptom relief. They reduce stiffness, and they make the patient feel much better today. But, and this is a big but, they have absolutely no impact on the actual disease progression or joint destruction.
DMARDs, on the other hand, well, they might take weeks or even months to show symptomatic benefit, but they are actively slowing down those destructive joint changes right at the cellular level.
All right, Section 3, First-Line Defense Tactics. Deploying our non-biologic DMARDs. Let's look at the heavy infantry of our treatment algorithm.
Our first-line arsenal is actually incredibly robust. Methotrexate, or MTX, is often chosen right off the bat because long-term data shows superior outcomes. Then we have leflunomide, which offers similar efficacy, but it has a loading dose that provides a really fast response. Now for milder RA, we might use hydroxychloroquine because it lacks severe toxicities, or maybe sulfasalazine, which shows its anti-rheumatic effects within about 2 months. And hey, when methotrexate fails, we have tofacitinib. This is a non-biologic JAK inhibitor, meaning it targets those exact enemy radio towers we talked about earlier. And often combination therapy using 2 or more of these agents is required when a single drug fails to hold the line.
But here's the catch. These powerful drugs require constant, strict surveillance to prevent friendly fire. Methotrexate and leflunomide require baseline and then frequent ongoing blood tests, usually every 1 to 2 months, just to monitor for hepatic injury and any drops in blood cell counts. Even hydroxychloroquine requires a baseline eye exam and then annual follow-ups to check for retinal toxicity. We literally have to watch our own troops as closely as we watch the enemy.
Which leads us to Section 4, Special Forces, our biologic DMARD treatments. These are the elite units we deploy when the non-biologics just aren't cutting it.
Let's move to and see how this builds upon what we've learned. These biologic DMARDs execute precision strikes against the exact cytokines and cells we identified during the initial invasion. We've got TNF-alpha inhibitors like etanercept and adalimumab directly intercepting inflammatory signals. Co-stimulation modulators like abatacept physically block the CD80 and CD86 receptors, which completely stops T cells from ever activating. We even have B-cell depleters like rituximab and IL-6 receptor antagonists like tocilizumab. These are highly advanced, incredibly targeted weapons.
However, as you might expect, elite weapons come with severe risks and extremely strict rules. For instance, TNF-alpha inhibitors must be avoided in patients with heart failure, and they actually carry a risk of triggering a multiple sclerosis-like illness. Also, because all biologics heavily suppress the immune system, every single patient absolutely must have a tuberculin skin test before use to check for latent TB. Furthermore, live vaccines strictly prohibited while on these therapies. And this is crucial. We never, ever combine biologic DMARDs together because the compounded risk of a severe infection is simply way too high.
Now, what's really interesting about this slide is this fascinating monitoring paradox we run into. Non-biologics, like methotrexate, require strict, routine laboratory blood draws every few months to check liver and cell counts for the entire duration of the therapy. But most biologics, like etanercept, despite being incredibly powerful immune suppressors, they require absolutely zero routine laboratory monitoring after that initial tuberculin skin test. It's a really surprising contrast in how we manage long-term maintenance. All right, let's wrap things up with Section 5, Evaluating the Outcomes, Securing the Peace in the Joints.
The ultimate goal of this medical war is, of course, complete remission, or at least very low disease activity. So what do our victory conditions actually look like on the battlefield? Well, it includes a physical reduction in joint swelling and warmth, and decreased tenderness when you palpate the joint. For the patient, it means a significantly shorter duration of that morning stiffness, a much longer time before afternoon fatigue sets in, and most importantly, maintaining the ability to just perform their normal daily activities. Remember, we are not just treating numbers on a page here. We are trying to restore a patient's life and their daily function.
And this brilliantly illustrates a core philosophy in managing rheumatoid arthritis. Once therapy is actually underway, routine laboratory monitoring is of very little value in assessing clinical response. Now, it is absolutely essential for detecting adverse drug effects, for sure, but to know if we are actually winning the war, the patient's physical symptoms, their joint mobility, and their daily function tell us the true story, not their blood work.
We have covered a tremendous amount of ground today, from the chaotic cellular battles of the immune system to the highly advanced biologic weaponry that we use to restore peace. But it leaves us with one final, truly fascinating thought to ponder. If our bodies have the immense power to destroy our very own joints, what does the future of targeted medical special forces look like in completely reprogramming the immune system? Thank you so much for joining me for this explainer. I hope this deep dive leaves you eager to explore the incredible, ever-evolving frontier of immunology. Keep questioning, keep learning, and I'll see you next time.